Hi, everyone. Thanks for joining us. I'm just going to pull up my presentation here. Okay. So I will do my best to keep track of questions throughout the presentation and check once in a while. But if I don't get to it during the presentation, I'll make sure to check it at the end. Okay. All right. So this is just a brief outline of what we're going to focus on. There's a lot that we can cover, and I could talk about this for a long time. I've tried to sort of break it down to sort of the few pertinent things and the things that I find that I spend most of my time talking about in clinic when I'm seeing patients. So the first thing is just a sort of an outline of shoulder anatomy. So this is a right shoulder, and we're looking at sort of the front of the right shoulder. And the first things that we kind of talk about are the bones of the shoulder. And so we have here the scapula, which is the shoulder blade, the humerus, which is the arm bone, and those two together make the shoulder joint. Then we have the acromion here, which is the top of the shoulder blade, and that kind of forms the apex of your shoulder, kind of that bony prominence that you feel on the outside of your shoulder. And of course, the clavicle, which is the collarbone. Then the soft tissues we will generally talk about in the office, or that I look at when you come to see me for shoulder pain, is the bursa, which is a little fluid-filled type sac that lives over the rotator cuff right underneath the acromion. The rotator cuff, which I'll get into in just a second, but it's comprised of 4 muscles that attach on the shoulder blade, or originate on the shoulder blade and attach on top of the humerus. Then there's the biceps, which this is slightly non-anatomic. There's actually 2 origins. There's this one here that is inserts inside the shoulder, and then there's one that actually originates up on this bony process on the shoulder blade. And then finally the labrum, which sometimes we talk about, which is a ring of cartilage that sits on the socket part of the shoulder joint that adds as like a doorstop and provides stability to the joint. Then there's, as I was talking about, so the glenohumeral joint is the joint that is between the humerus and the shoulder blade, which is the main shoulder joint. So when I say shoulder arthritis, that's what we're talking about. The acromioclavicular joint is the joint between the collarbone and the top of the acromion, which is what people are talking about when you say a shoulder separation. So that's injury to this joint. And then there's a subacromial space, which we'll talk quite a bit about in a little bit, which is the space underneath the acromion, so subacromial, that lives where the bursa lives, and also the top of the rotator cuff. So all these things will more or less become pertinent as we get through this talk. So a little bit of anatomy of the rotator cuff muscles. Again, when I talk about the rotator cuff, we're talking about 4 different muscles. So the main one that is usually involved in shoulder pain is the supraspinatus, which is the tendon that sort of sits on top of the shoulder blade and inserts right on top of the humerus here. Then there's the infraspinatus, and that sits sort of on the back part of the shoulder blade, and that muscle actually works. It's an external rotator, so it rotates your arm out away from the body. The supraspinatus helps lift the arm up overhead, kind of like this. Then there's a subscapularis, which sits on the front of the shoulder blade, and that rotates your arm in, so an internal rotator. And then the teres minor, which is a smaller muscle that also is an internal rotator in a different position, sort of when your arm is in 90 degrees away from your body. So that's kind of a rough anatomy of the shoulder. So the first thing I'm going to talk about is impingement, because that's probably the most common thing I see. And as you'll see here, it's the most common cause of atraumatic shoulder pain. Sort of in a rough summary, it's basically abutment of bursa and rotator cuff tissue between the humerus and the acromion. So it's basically the tissues are getting pinched. And here's just a nice visual for you guys as to what that actually means. So on the left side of the screen, your left, you see sort of normal function, normal anatomy and kind of normal mechanics of the shoulder, whereas as the deltoid and the rotator cuff muscles move the arm up, the ball glides smoothly and the rotator cuffs glide smoothly under the acromion, and it's a nice smooth arc of motion. When you're talking about impingement, which is the visual on the image on the right with all the red, for various reasons, you develop abnormal mechanics in the shoulder, and when you lift your arm up, that rotator cuff and the bursa gets pinched between the two bones and it causes pain. And that's what we talk about when we talk about impingement. So the things that cause impingement, you know, certainly anatomy is a big component of it. Some people have an acromion that's kind of hooked, and so that sort of predisposes you to getting things pinched. It's just your normal structure that you can't really get away from. It's what you're born with. A big part of it is improper shoulder mechanics. So poor posture, and you know, if you sort of, we do a lot of things in front of our bodies, and if you sort of stand with your shoulders hunched forward, you can imagine that kind of rolls the acromion or the apex of the shoulder forward and narrows that space. And then muscle imbalance. So if you have weak rotator cuff muscles, or if one muscle is stronger than the other, or if there's inflammation in the rotator cuffs, muscles, or injury like a rotator cuff tear, that all certainly can predispose you to developing poor mechanics that then lead to impingement. Age is a part of it. You can get arthritis in the acromioclavicular joint. You can also get some bone spurs on the acromion that can, you know, essentially rub on the bursa and rub on the rotator cuff and cause that type of, those types of symptoms. And sort of the overarching issue is overuse. And so if you have all these things going on, so your anatomy predisposes it to, you have improper shoulder mechanics, there's muscle weakness, and then you do a lot of things like, you know, overhead activities, you know, if you spend the day cleaning windows, or you do a lot of pickleball, you suddenly do a lot of swimming, it can, that sort of repetitive overhead motion can kind of induce those symptoms. So again, here's just a quick look at poor posture. So good posture, your shoulders are back, shoulder blades are sitting flush on the chest wall, and that sort of keeps the mechanics of the shoulder blade in line. And so as you move your arm, your shoulder blades move smoothly, and everything kind of moves out of its way and moves properly. When you have poor posture, when your shoulders are rolled forward due to various muscle imbalances and weakness, that can predispose to impingement. So the symptoms are, you know, the most common one is pain. Usually people will say, it hurts for me to lift my arm up. I can't reach in the cupboard in the kitchen. I can't do my hair. I can't wash my hair. That's very common. And then also pain at night. A lot of times people say, if I turn over onto that side, it hurts. Those are probably the two most common. Sometimes there's also associated weakness, which is sort of pain inhibition. You know, you feel like you can't use those muscles because it hurts. A lot of times people will also complain of popping or catching or grating with shoulder motion. And in this setting, a lot of it is due to inflammation and scar tissue, and just sort of that bursa gets thickened and inflamed, and as it rubs, it pops. And so that's a very common complaint. And usually this is what we call an atraumatic event. So there's no specific injury. It's, as we talked about, it's usually just overuse. Although sometimes people do develop shoulder pain without any specific activity. It just comes on, you know, if you do one day of something that you don't normally do, can certainly set it off. Or if you spend a day cleaning, it just kind of comes, you know, there's no real rhyme or reason other than it's a very slow, insidious onset, and it doesn't go away. So, you know, if you come to me with these types of complaints, I will almost always, unless there's some strange, unique situation, this is, you know, treatment is non-operative, so it's conservative care with the you know, what I call the golden triad. So I always say, you know, right to my patients, you want to do at least 2 of these things, ideally all 3. So the first line, you know, the first thing I'll always say is getting you onto some sort of an anti-inflammatory regimen. And that usually means not necessarily taking an ibuprofen here or there. It's taking a full strength anti-inflammatory for at least a week and up to 2 weeks. And the idea is not to get rid of the pain, it's to get rid of the inflammation that's going on in the shoulder. And a lot of times I'll talk about, you know, providing you with a prescription. The other thing that we can do is provide an injection, and you can see an image here of this. This is what, you know, where I approach from the back, an injection into the subacromial space, and the injection is of steroid and a numbing medication, like a lidocaine type medication that can, you know, I always say it's like pouring water on the flame. So it's usually very helpful for people who are struggling at nighttime to sort of kickstart the anti-inflammatory effect. So that's sort of what I'll do in the office. And then the other thing that I'm a big proponent of is physical therapy. I think it's really important, especially for shoulder pain, because it's really hard to correct your own improper shoulder mechanics. You know, I definitely have a lot of people that will come to me from other physicians, either it's a primary care provider or somewhere, that they get an injection, they get anti-inflammatories, and it helps for a month, but then they don't actually do anything else, and then it comes back. And the problem is that you don't address the underlying issues, and it's really important to correct those things. And physical therapists are really good at identifying what are the muscle imbalances, where's your posture off, and how do we correct that. And it's really hard to do that on your own, so I always encourage that. And then the other thing that a lot of people find quite difficult, especially very active people here in Bend, is activity modification. So you have to stop the thing that makes it hurt. So, you know, I've definitely had patients that will come in and they have shoulder pain, and we do these things and they say, well, it hurts to play pickleball. And then I see them back a month later and they're like, yeah, you did all these things. I'm doing therapy, I'm doing anti-inflammatories, but it still hurts because I'm still playing pickleball. Well, you have to sort of stop doing the thing and sort of build from the ground up to correct the the issue, and then you'll be able to get back to your activities pain-free. And I'm just going to pause for a second. I have 2 questions that popped up. Okay, so the first one, so there's a couple that I'll address. There is a question about low-grade articular, like partial thickness rotator cuff tears. I will, you know, I'm going to save that for the end. I'm going to talk about rotator cuff tears. That's a very specific question. So I'm gonna hold off and address that at the end, if that's okay, because hopefully we'll touch on some of these things, and then you know, and then I'll address more if we didn't get to them. Okay. All right. I'm just gonna hold off on that for now. Okay. So moving on, and so in some cases, it's not, you know, sometimes it does happen where people continue to have pain. So they come, you know, you do the injection, it helps, you do the therapy, and it comes back. And then in that situation, you know, I will usually get an MRI. And then if there's a lot of inflammation and if there's bone spurs, then we talk about doing what we call a subacromial decompression, which is the goal of that is to basically open up the space for the rotator cuff, so you don't have the bony sort of things that are getting pinched, and you get rid of the inflamed bursa. And I do it arthroscopically, and there's just a sort of a rough drawing of it here, where the camera or the arthroscope is in the back of the shoulder, sort of looking to the front. And this is the shaver or a burr that we use to remove bone spurs, and then I'll also work through this portal here to remove any inflamed bursa and sort of clean things up. To open up the space. So that's kind of impingement in a nutshell. Rotator cuff, so this is a big sort of big topic, and we'll you know, I'll try to do my best to cover it as thoroughly as I can. So when you talk about rotator cuff tears, you sort of have 2 pots. You have the acute tears and you have the chronic tears, and I'll cover both of them separately. But both present with similar symptoms. You know, the main symptom is pain, and the pain is often localized right to the outside upper arm, sort of over the deltoid, and a lot of times it can even radiate down to the elbow. Night pain is a big one. So if there's a lot of pain at night and it wakes you up from your sleep, that can indicate a rotator cuff tear. And you know, in the case of acute tears, you know, the pain can be quite severe after the injury, and you can have actual loss of function and weakness. But more chronic tears, the pain is usually sort of similar to impingement type of pain, where there's pain with overhead activity. So you'll see that there's a lot of overlap with the chronic rotator cuff tears and impingement. So for acute tears, usually there's an event, you know, you either fall or you're lifting something heavy and suddenly you feel a pop. Patients over the age of 40, if you have a shoulder dislocation, a lot of times we're concerned for an acute rotator cuff tear. So I tend to be more aggressive with those, and I'll come into my office, I get an MRI right away. But that injury is usually associated with sudden pain and loss of function where you really can't lift your arm. And that's when I start to worry about a rotator cuff tear. And treatment, if I get an MRI and you have an acute full thickness, meaning that the whole tendon's off, rotator cuff tear, then almost always the indication is to fix it surgically. There is some exceptions. For example, if there's significant underlying arthritis in the shoulder joint, so in the glenohumeral joint, we might have a discussion about treatment options, different treatment options for that. If on the MRI there is significant degeneration of the muscles of the rotator cuff, which indicate that maybe it's a chronic tear that's been exacerbated, that's, sometimes we'll have a discussion about treating it conservatively because those tears might not be repairable or they might not be amenable to healing. And then the most important thing, again, I'm going to keep harping on this, is that a patient is, for whatever reason, unable or unwilling to follow through with physical therapy after surgery. I mean, I always tell my patients, my job in a nutshell is the easy job to fix it. You have the hard job of following through with therapy that can be months. So it's really important that you're sort of committed to it from day one and follow through until that physical therapist says, I'm happy with where you're at. And I say, I'm happy with where you're at, and we discharge you and off you go. And then finally, of course, poor surgical candidates. So if there's, the risk, other significant comorbidities which make you too high of a risk for surgery, then we might have a discussion about non-operative management. So moving on to chronic, let me just see if there's any, keep forgetting, I think there's another question that came up. Shoulder, so a question about shoulder separation. Yeah, I have to kind of, these are very specific questions to each patient, which, honestly, we'll have to try to address, I think, at the end, because I think it could take a little bit of time. For Marjorie, your question about shoulder separation, I separated my shoulder going over the handlebars about 9 years ago, recovered without surgery. Pain is increasingly intense as of this year. So, if you completely recovered from this injury 9 years ago and suddenly there's pain again, my question is there something else going on? It's very unlikely that an old injury from 9 years ago is the cause of your pain now, unless there's been a new injury or you've somehow re-aggravated it. So my first thought, certainly, obviously, we'd have to do a pretty thorough exam on you, but my first thought would probably be to, if there hasn't been an injury, start out with, physical therapy and anti-inflammatory. It doesn't necessarily mean that's the only answer, but there hasn't been a new injury, then most likely it's one of these sort of chronic, like an impingement or a bursitis type of picture. I don't want you to think it's the only answer, but a lot of times it can help. Okay. So going back to chronic rotator cuff tears, so these are usually seen in older patients, and the main issue is it's intrinsic degeneration of tendon tissue over time. It's just something that we can't really fight. It's sort of, the rotator cuff tendons in general don't have good blood supply, even in young healthy patients, and so as you get older, that blood supply it gets worse, and then you just more likely, the tendon just starts to degenerate, and so it's more likely to be worn. You kind of see this picture of the rope. I mean, it's sort of the same kind, it's an old rope that gets worn out, and over time it starts to tear. And so, these kind of tears are a lot of times on the spectrum with impingement. So you can imagine if your shoulder is getting rubbed and the rotator cuff is getting rubbed with bone spurs and bone over time, that tissue can start to fray, and you can start to develop, you get chronic inflammation, the tissue weakens, and then it, frays further, and you can develop partial thickness rotator cuff tears, which then can over time potentially progress to full thickness tears. Why isn't this advancing? And so the general sort of epidemiology of chronic rotator cuff tears, there's been some studies that have been done that have shown that the prevalence of these in older individuals is quite substantial. And we're talking full thickness, asymptomatic, meaning patients don't even know that they have a rotator cuff tear. So over the age of 60, almost 30% of people had asymptomatic tears. And then in people over the age of 75, 65% of people had them. So it's a pretty common thing, which kind of tells you that a lot of people are living with these issues, and it doesn't necessarily mean that you need to have it fixed. So risk factors associated with developing rotator cuff tears is, again, age is the big one, smoking, high cholesterol, and then family history can certainly play a role as well. And then, we do know that the prognosis of these is that 50% of tears that are asymptomatic. So you know, if you get an MRI of a shoulder for other reasons and you happen to notice a rotator cuff tear that's not causing symptoms, about half of those will become symptomatic over the next 2 to 3 years. And then of symptomatic tears, 50% of them will get bigger over time. So the bottom line is, if you have a tear, it's likely that it'll at some point become symptomatic. And then if it's bothering you and you don't do anything about it, it's likely that it'll get bigger. And, you know, as a kind of common things making sense, bigger tears get bigger faster. So if you have a little tear in a piece of paper, you know, you're less likely to catch it and fully tear it, versus if there's a big tear in the piece of paper, you know, you catch it, you can fully tear it. It just kind of makes sense. And this little box here, it just kind of shows what we use when I'm talking about you have a small rotator cuff tear or you have a medium-sized rotator cuff tear. We're talking about size of the actual tear, sort of front to back, you know, so less than a centimeter. And so you can kind of see kind of what we're thinking about and what we're looking at in terms of size and what's going on inside your shoulder. So, so again, the first line of treatment for degenerative atraumatic tears, and again, as a, you know, we have to sort of talk about, you know, how big are they? And I mean, we talk about asymptomatic, degenerative atraumatic tears is non-operative. And, you know, I think a lot of them are thinking, well, you just said that a lot of them are going to get bigger and a lot of them will become symptomatic. And it's true. Yeah, I mean, it's, you know, 50% of people, they will continue to get bigger, but you know, it's possible that you will need to have surgery at some point. But if you come to me and you haven't had injury, I'm not going to jump onto getting an MRI right away. I think I'm more inclined to treat it conservatively, because it's very possible to get you back to where you need to go, and you don't need to have anything done aside from these, you know, this non-operative management and sort of kind of the triad as we talked about before. And in sort of in my practice, I think, you know, I come in treating you this way, 80% of people I found do improve and won't need anything else done and kind of get back to their activities without any further intervention and avoid surgery. And then again, you know, if you continue to struggle, or if, you know, you successfully treat you temporarily and then the pain comes back again, then that's when we talk about surgery. And the surgical repair again is arthroscopic, where we the image where I prefer to do it arthroscopically through little poke holes in the shoulder, and we actually had shown an image of what it looks like when we do the repair here. You know, I usually use 2 to 4 suture anchors, so I put, you know, 1 or 2 sort of closer to the joint and then a couple on the outside, and I basically pass stitches through the tendon and compress it down to the bone, and that tends to work quite nicely of getting these repaired. And then, you know, some people do it open, which is just surgeon preference. I usually reserve open surgery for massive tears, so really big tears involving more than one rotator cuff, and especially if they're really retracted, meaning that they're sort of, the tendon as it comes off the bone, it gets pulled over to the glenoid. It could be tricky to pull it back. Or in some cases, if you've had a rotator cuff repair and then it's failed, sometimes you might consider doing it open. So I try to not do that unless I absolutely have to. And so then if you have had surgery, then the question is, well, what's recovery? And so the main thing is that you have to think about is that healing is very slow for this tissue. And again, part of that is because the blood supply in the tendon is at baseline not very good, and as you get older, it gets even worse. And so in general, we know that it takes anywhere between 2 to 3 months for the tissue to heal down to bone. And so I always say kind of at 3 months is sort of you're as healed as you're going to be potentially. And certainly in older individuals, it's slower, and also in people who smoke and in diabetics, just because the vascularity is even more compromised in those individuals. And then we also have to think about sort of failure of repair. So some people just don't heal, and sort of the older you are, the more likelihood that it won't heal. And you know, and again, a lot of it is because of blood supply, although that doesn't necessarily preclude you from surgery. You know, I think that there has been some data coming out of various institutions that older individuals with rotator cuff tears do just as well as people who are younger. Other failure risks are if you have a larger tear. And of course, as we talked about, muscle degeneration. So that means that there's the muscle, because it's a bigger tear, and if you haven't been using the muscle, you can get some fat infiltration into the muscle belly, which means that the muscle is just not as amenable to healing. And then the other thing is, of course, not following post-op protocol. If you do too much too quickly, you could just basically pull the repair out, pull the tendon out of the suture. Checking questions, think we're okay. And then my standard sort of recovery timeline for you, and this can vary based on different patient factors and how big the tear is, but sort of the general average recovery, the first 6 weeks, I usually have you in a sling, this kind of pillow sling you see here. And I do get you into physical therapy at your first post-op appointment, really focusing on just passive motion and just some mobilization, just so you don't develop too many adhesions to the in the joint. Although not doing therapy, studies have shown that not doing any therapy for 6 weeks ultimately does not change your outcome. So I think it's just slower in the beginning, but a year out, most people, whether or not you did therapy in the first 6 weeks, your outcomes are the same. But I like to get you into therapy because I think people like to feel like they're moving and making progress, and I think it helps with the pain. Then the second 6 weeks, so standard orthopedic unit is 6 weeks. So the second 6 to 12 weeks, get you out of the sling, and then now you're really focusing on active and passive range of motion. And the goal is to get within sort of normal, really reestablish normal shoulder mechanics, and get, have your range of motion start to approach that of the contralateral side. And so once you can, in the most important, raise your arm up without shrugging, and sort of you can reach, you're starting to be able to reach, that's when you can start to do some strengthening, which is usually no sooner than 10 weeks after surgery. If it's a bigger tear, then I would be more conservative and probably wait the full 12 weeks. And then ultimately, I always tell my patients it's about a 6-month recovery, and it's a pretty conservative estimate. Some people 4.5 months are sort of back at it and feel good, but 4.5 months to 6 months. So it's a slow process, and you have to sort of just be diligent and be patient and be diligent with your therapy, and you will get there. Okay. So let me see if there's another, I think there's a rotator cuff question. So I have a low-grade articular-sided surface tear of the subscapularis, and a moderate partial articular surface tear of the supraspinatus, some fraying of the posterior superior labrum. Should I be doing any stretching? What exercises should I do? So that's a good question. So that's the type of individual for you at physical therapy back in June, frozen shoulder, and again back in October. Should I go back? So it's so the question is, are you having frozen shoulder, or is your pain more related to the rotator cuff injuries? And it's a hard assessment to make, but if you're still struggling, I'd say, oh, maybe those are two different. Sorry, are those two different questions? I'm not sure. But in terms of the low-grade articular surface tear, so I would say if you came into my office for that, I would send you to physical therapy. The moderate grade partial articular surface tear, that tells me it's probably about 50%. And I'll kind of touch on that at the end. That's sort of approaching sort of borderline, where if you are still struggling with pain and you're doing some therapy and it's not really helping, then you might consider being more aggressive in terms of going in and repairing it. Because there's certain, the literature sort of shows that there's certain cutoffs in terms of how much of the tissue is torn, which tells us whether or not you're going to do well with conservative treatment. So with that supraspinatus tear, you're kind of borderline. I'd love to see the MRI and see what it looks like, but I think that if you haven't had any treatment, I would definitely start with some physical therapy where they can go through some exercises for you. And unfortunately, I don't have any kind of pictures of exercises that you would do at home, but I'm happy to, if you want to reach out, to Jamie or me, we can sort of get you set up, or I'm happy to see you, or we have some basic exercise handouts that we have in the office. And then I don't know if this frozen shoulder question is, I don't know if it's the same person or not, I can't tell. But so that physical therapy back in June for a frozen shoulder, and again back in October for pain. Should I go back? So I'm interpreting that as the frozen shoulder was in June and the pain is now back in October. And you know, that's a tough question to sort of answer. I mean, it's a question is it the same pain? Was there an injury? But if it's the same kind of pain, and it's still, you know, frozen shoulder can take, and I'm actually going to touch on that shortly, but that can take, you know, months to more than a year to resolve. And so, you know, if the frozen shoulder was in June and you're still struggling, you probably need some more therapy. But otherwise, you know, probably an evaluation to see what else is going on. Sorry, these are kind of hard to answer without a little bit more information, but I'm doing my best. And then, okay. And then let me just finish. There's some really good questions here. I'll get to these. Let me just go through, answer some questions. I hope maybe see if I can answer some questions, and then we can kind of address whatever's left. So the other, you know, I kind of grouped the rest of the stuff that's going on with the shoulder into what I call the other itises. There's, you know, there's a lot that can be unwrapped here, and I could probably sit and talk about every single thing for another 40 minutes. But I try to sort of summarize and touch on everything. So the frozen shoulder, which is also the clinical term is adhesive capsulitis. And what that is you can see the image here, it's inflammation and thickening of the actual shoulder capsule. So it's another part of the shoulder that I didn't really address in my anatomy, but it's basically, it's not tendon. So these are ligaments. So they're not tendon and it's not bone. It's actually tissue that connects bone to bone, provides some stability to the shoulder joint and actually sort of envelops the joint. And if you get inflammation of that capsule, it gets thickened and it gets leathery and it gets really tough. And so you start to, first it starts out with pain and then it's followed by progressive loss of motion. And an acute frozen shoulder, it can be quite severe pain where people can't even really move. People come in and they can't move their arm and it's pretty sudden and quite distressing. And it's very common in women in their kind of 40s to 60s. Usually the cause is unknown. We don't really know why it comes on. Sometimes if you've had a trauma to the shoulder, you can get post-traumatic frozen shoulder. And then the other thing that we really worry about is post-operative frozen shoulder, which can certainly happen in certain individuals. We try to prevent that with therapy and things like that and try to identify high-risk patients. It is associated with diabetes or hypothyroidism. So if you have those, then you're kind of more likely to get them potentially or higher risk for that. And then if you have cervical disease, neck type of issues, that can certainly is also been found to be associated with that. And the natural course of it is a freezing stage where the shoulder is incredibly painful and you really can't move it. And it just, you just come in and you just don't even touch my shoulder. And that's sort of the acute freezing stage. And that really, you could do a little bit of therapy, but in that period, you really have to treat the shoulder with kid gloves because it can actually, if you are too aggressive too quickly, you can actually flare it up and sort of work against yourself. And it's just very uncomfortable for the patient, very painful for you, and it doesn't really get you anywhere. So someone comes in with an acute frozen shoulder, a lot of times I'll put them on an anti-inflammatory, maybe giving them an injection, have them do some gentle kind of pendulum type of exercises where it's just like a hanging passive motion exercise. And then once that acute phase calms down, then we get them into therapy, maybe a couple weeks later, just so that they can tolerate it basically. And then PT until, you're blue in the face is the way to go. Sometimes if you continue to struggle with stiffness, even, if you plateau with the therapist and you really can't seem to break through, rarely we have to go to the OR and do a manipulation under anesthesia where, literally go to sleep and we, take the tissues and rip them basically and kind of reset the clock. And then you're in therapy every day for 2 weeks. And it's it's like a race against time because you can recur, if it's quite severe, quite significant trauma to the shoulder. So you really have to, once you tear the tissue, you got to get moving pretty quickly. It's, it's a problem, and it definitely can, like I said, it can take about more than a year to go away in patients who are trying to treat it conservatively. Yeah, so here's someone about frozen shoulder. 8 years ago, frozen shoulder. I have about 95% mobility, constantly have low-grade pain. I also experience weakness in the shoulder. Occasionally see it loosen. I was wondering if there's anything else I can do. So again, 8 years of frozen shoulder pain. I mean, maybe that's what it is, but there's probably some other underlying issues going on. Again, it could go back to shoulder mechanics. Maybe you have some underlying arthritis. So there's definitely other things that we could do. Weakness. I mean, that could be rotator cuff. So, if it's just because you had an issue 8 years ago doesn't necessarily mean that it's still the same thing. So if it's still really bothering you, then I implore you to get formally evaluated or maybe even go into physical therapy. But, in that kind of situation, I'd be happy to see you and do a formal exam. And then I'll look at, so answer that one. And then, sorry, we're almost done, and then I'll go through. There's a lot of questions I'll try to answer. The other thing, so biceps tendonitis, as we talked about, there's a biceps that originates inside the shoulder and runs in the front of the shoulder. It's very common to have inflammation in there, especially if there's other things going on. And again, overuse is the most common. You can see this is an inflamed biceps here. It's also often associated with impingement and rotator cuff tear. So they all kind of go hand in hand. And the treatment for these is, again, non-operative usually, physical therapy, resting, injections. You can do an actual ultrasound guided injection into that area to try to get it to calm down. And then ultimately, if we need to do surgery, it's either, you can just snip it, and that actually works fine because you still have that other origin on the chest wall. And so it actually doesn't impact your function in terms of strength in any way. But some people with very thin arms, especially very muscular arms, could get what we call a Popeye deformity. So they get a little bulge in the arm. And some people just don't like the idea of having a tendon cut. And so what we do is we can reattach it sort of lower down, kind of right down here. I usually go through a separate little incision, reattach it lower down, and cut out the part that's all inflamed and injured. And then finally, arthritis, again, a whole other topic, but briefly, this is certainly a culprit of shoulder pain. It can cause a lot of other problems. So you can get arthritis in the acromioclavicular joint, which is the joint between the AC, between the acromia and the clavicle. And that's commonly seen in people a lot of people that are manual laborers, or people that do a lot of heavy lifting it's very common. Or if you got injury to that joint, you could get secondary arthritis there. And then, of course, shoulder arthritis or glenohumeral arthritis is a very common thing. And there was a question about why it hurts at night. And to be honest, we don't know. I mean, arthritis notoriously causes pain at night, just like rotator cuff tears. And we don't really have a good answer for that. Partly it might be just because of, you've been using your arm all day, and then suddenly all the distractions are gone and you're not doing anything. And but honestly, we don't know why nighttime is the worst. And so the final thing before I get to all the questions is the neck. So this is a big thing. There's a lot of overlap between neck pain and shoulder pain. And I have, a good amount of patients that are referred to me or come to me because they're having shoulder pain. And it actually turns out that their pain is coming from their neck. So pinched nerves or arthritis, things like that. And so, and I don't, that's not, as a patient, that's not your job to figure it out. If you're having shoulder pain, you come to the guy the gal that treats shoulders, and it's my job, but it's just sort of things I think about. So you come in to me to see me for a shoulder, I always do a neck exam first. Because, the thing is that if I miss a neck problem and I start focusing on the shoulder and we do injections and I do, surgery, and it's actually coming from your neck, you're not going to get any better. And that's my fault. So we always have to make sure that the neck's okay and it's not actually coming from the neck. And so warning signs of when it makes me think neck is definitely numbness and tingling. Very rarely does that come from the shoulder. Sometimes if you've had an injury and there's a lot of inflammation, you can get some secondary transient numbness, but persistent, constant numbness and tingling that goes down into the hand, that's either local, something going on in the nerves locally in the arm or the forearm, or it's more likely it's coming from the neck. And then, if you come to me and you're having shooting pain on both sides, especially if it goes down below the elbow, that to me is another warning sign, because shoulder pain doesn't go below the elbow. So if you're having stuff that's going down into the hand, doesn't mean that you don't have shoulder a shoulder issue, but there's probably something else going on. And then any kind of hand weakness. So if you lose, grip strength, or you find that your handwriting is changing and you can't hold a pen well, or you're struggling with dexterity, so like buttoning your buttons or things like that, that's again nerves. And so all those things, you have to sort of consider and be aware of and make sure that you don't miss that. And then if you're, obviously if there's, you're moving your neck in some way and you feel the shoulder pain and you feel shooting pain, like almost like a sciatica in your neck, that's probably more of a neck focused issue as opposed to a shoulder. So that's kind of I think that's all I got. So so there are a couple of questions that were sent in initially, which I'll try to address. So with a rotator cuff tear, that is not operable. And so what that means is it's a chronic retracted rotator cuff tear, which means a tear that you've had for a long time and the tendon's retracted, the muscle's atrophied, and so it's basically not repairable. Excuse me, what movements or activities should be avoided? So honestly, it's basically what makes it hurt, in a nutshell. Thankfully, we don't walk on our arms, so you're not going to be running on your arms, or maybe you are, in which case that's amazing. But generally, things, when there's a rotator cuff that's not repairable, we worry about arthritis. And so, I'd say probably want to avoid heavy lifting. So maybe not do, bench press or power lifting. But other than that, it's really just whatever it's quality of life. So if if it makes you happy to play pickleball and you have an irreparable rotator cuff tear, then play pickleball. There's not really anything that needs to be avoided, because ultimately the solution for that is most likely a shoulder replacement. And we try to, just as a knee replacement and a hip replacement, we try to avoid that for as long as possible, as long as it doesn't impede with your quality of life. So how does one best deal with a partial tear of the supraspinatus? So we talked about this earlier, so I put up a picture of what we talk about when we talk about partial tears. So what we're saying is, it's the rotator. I always say the rotator cuff is it's string cheese. So you get partial tears means that there's some parts of the fibers that are torn off, but it's not a through and through tear. So the tissue is still otherwise intact. And so there's articular sided tears, which are tears that originate on the inside of the joint and sort of move out towards the subacromial space. And then there's the bursal sided tears, which start on the bursa where the impingement is and move in towards the joint. And so, as we say here, the tears that I'm generally more aggressive about in terms of talking about maybe doing something surgical is if there is a tear that involves more than 25% of the tendon on the bursal side. So really, anything beyond grade 1. So any of the, even 50% of the tear, so it's a pretty low threshold to be aggressive with these types of tears. And then partial thickness articular tears, we can have a little bit more leeway here. Anything really, any 50% or up, so kind of grade 2 and up, is where it tend to be a little bit more aggressive. And it's just because it's just a weaker tendon and more likely to continue to be symptomatic, more likely to progress, and less likely to be successfully treated with conservative treatment. So, and in these cases, what I normally do is basically complete the tear and just repair it down like I would a full thickness tear. And if we do have to go in and do a clean out of a tear that's very kind of low grade, as you see grade 1 tears, usually it's just a little cleanup. I don't usually have to do anything, although to be fair, when I am operating on partial thickness tears, I find that they usually are higher grade, and meaning that I can very, very easily poke through them and complete them, and it doesn't take a lot to break through that tissue. So, depending on the size of the partial tear, I'd always start conservative, and then if it continues to bother you, then we can talk about surgery, and same thing, injections, physical therapy, anti-inflammatories. And then in terms of nutrition needs for healthy shoulders, there's not really anything specific. I mean, obviously a well-balanced diet, but the most important thing is to stay strong and kind of lumbar and mobile. It's really more just maintaining, kind of all the stuff that we talked about in terms of posture and good mechanics in the shoulder, and less so about nutrition. There's really nothing that's been proven out there that's, you need to eat, a pound of turmeric a day and your shoulders will feel great. Unfortunately, there's not really a silver bullet like that. So just good healthy nutrition. Obviously, avoiding diabetes is a big one, as we talked about. It's a risk factor for a lot of things, and not smoking, and just sort of the stuff that your primary care doctor always tells you. And then let's see what other questions we have here. Safe, how often can you get, so that's a good one. How often can I safely get steroid injections? So injection into the same area. So, you know, whether it's into the joint or the subacromial space, it's usually no more frequently than every 3 months, because there's an increased risk of infection. The other thing you want to consider is, you know, especially if you're injecting steroid over intact rotator cuff tissue, you know, we do know that steroid can potentially have a negative impact on the tissue and can predispose you to, can weaken the tissue. So I generally try not to do more than 3 unless I absolutely have to, unless you have sort of irreparable rotator cuff tear with end stage arthritis and, you know, and not a good surgical candidate, then, you know, I have had patients that just come in routinely once every 3 months for a shot. Supplement, is there a supplement or something that will keep tendons and ligaments healthy? Nothing that's been proven. I mean, you know, I think nothing that I can really attest to in the literature. Again, I think the most important thing for keeping tendons and ligaments healthy is to maintain mobility, don't get stiff, and stay nice and strong. So if you have any torn muscle in your shoulder and time has passed, maybe a year, isn't it too late to attempt to pull the muscle back? So again, that depends on, so yeah, if it's a big, so if it's a big rotator cuff tear, and there's certain things that we look for on MRI that will tell us whether or not it's repairable. If it's a big rotator cuff tear that's been there for a year, most likely it'll be very difficult to get it back. But again, it's sort of a case-by-case situation. You know, if you came to me with a big rotator cuff tear that you had a year ago, you know, I would definitely be, I wouldn't be like, oh, it's going to be 100% chip shot. It's going to be difficult. Then we'd have to have, you know, have a full assessment of what else is going on the shoulder, and kind of, you know, it's a little bit of a longer discussion as opposed to just let's fix it. Let's see. So I had a surgery for a medium rotator cuff tear, biceps tendonitis, and a labral tissue tear and cleanup. It's been 4 months with physical therapy twice per week. I still have a lot of pain in the shoulder at night and aches all day. Is this normal? I mean, 4 months out, you know, I definitely would like to see, you know, resolution of shoulder pain, especially at night, and that achiness usually, you know, it's more activity related as you progress in therapy. So, you know, if you came to me and I definitely have patients like this, I would be concerned with, you know, underlying, you know, frozen shoulder, or, you know, did the repair fail? You know, depending on what your exam is, I may consider getting a repeat MRI, making sure that there's nothing else going on. But also, to be fair, sometimes people just, you know, rehab slower. So it's, you know, it's certainly not abnormal to continue to still have a little bit of pain at 4 months. It just depends on how bad it is. And if it feels like it did before surgery, then I certainly would be concerned. Can you suggest exercises to do at home daily rather than going to PT? So I'm not gonna really demonstrate anything, but we definitely have some stuff that you can do. You know, we have handouts here in the office and we can give out bands, but a lot of it is just band work, sort of really focusing and isolating on the little rotator cuff muscles. You know, for the sake of time, again, I'm not really going to go through one by one because I think there's quite a bit more questions and wait, maybe not. Oh, she got rid of them. But it's really a lot of band work, a lot of shoulder, you know, kind of really focusing on strengthening the muscles in your shoulder blades. So really focusing on shoulder retraction, kind of rows, and you know, having kind of having a band and sort of doing external, sort of like external rotation out this way, you know, this way. Honestly, if you, and I hate to say this, but if you sort of go online and look rotator cuff exercises, I mean, there's so many different PTs that put stuff on YouTube. So if you really wanted to avoid physical therapy, that would probably be a good resource. But again, I would implore you to consider going to therapy, even for 1 or 2 visits, just to see, you know, just to have them do an assessment and make some recommendations. And I do have patients that come in and don't want to do therapy, and I say, at least just go and tell them, listen, I want a home exercise program. I don't want to go to therapy because of COVID or X, Y, and Z. And they can sort of they can demonstrate some things you can do and sort of get you at least rolling, so you're not kind of floundering on your own trying to figure out what to do. And let's see. Are the steroid injections? Yes. So usually the only injection that I don't do in the office is the biceps injection, and that's because that tendon's quite deep and it's a small space, and so I usually, I don't have access to an ultrasound, unfortunately. So I will refer you over to one of my colleagues. They're called physiatrists, who do a lot of injections under image guidance, and so they will do that injection on the ultrasound. Sometimes in certain situations, for example, if there's a bigger shoulder or something, for steroid injections into the joint, I might send you over to the physiatrist, but generally the subacromial injection, the injection into the acromioclavicular joint, and the injection into the joint, I'll just do in the office. What is my opinion of hang therapy from a bar? Well, I mean, I guess it just depends on what it is. If it's just trying to get trying to stretch it out, I mean, if it feels good, then do it. But especially, I mean, if you're in a situation where you have impingement or something, that certainly probably wouldn't make it feel very good. So, in that case, I'd say if you feel like it makes it worse, then don't do it. But, some people, certainly for just stretching sort of the lower portion of the upper trunk, can certainly be helpful. Did I miss anything? Any questions? I think I got them all. Hopefully that was helpful. I think that's it. I don't know if there's any other questions. I really want to say thank you guys for coming. Hopefully that was helpful. And one more question. Thank you. Thank you for being such a great source for us here in Bend. Always a pleasure. My door's always open. And I think, you can find out more about me and what I do and access some of our videos and things on our website. And happy to see you guys. And, the answer is, if you're not sure, come on in. Don't feel like you're coming in and wasting anyone's time. We're here to treat you guys. So hopefully this was helpful.